We kindly welcome you, sir, Dr. Rahul Yadav, to crystallize us on how to go about with the neurological examination of a newborn. We call upon the presenter, Dr. Pavlin.
Thank you, friends. It's my great pleasure to be here. So actually, this is the time, this case, we won't go in details about knowledge. We'll go for more for what we can say practical demonstration of some science and how to avoid failure in exam. I'm telling openly is because I am the person who has failed twice. Once I failed in MD, second again I failed in DM. So I know the both sides of the coin, why people fail and how to pass. People don't fail because of lack of knowledge majority times. People fail because of they are not good in practical skills. They are not good in aptitude or able to communicate that particular concept across the board. So this particular neurology of newborn will take as only an example by which we can stress upon the demonstration skills and at the same time some amount of theory also. So my friend will tell about all those things.
Good afternoon, everyone. We are going to divide the discussion into two parts, demonstration, which are the commonest things we do in pediatric and newborn rounds and ward. And first of all, the common one, that is anterior fontanelle demonstration. This is they often tell this is a pediatrician's handshake when the infant reaches your OP or clinic. The most commonly we do is we palpate the anterior fontanelle, and we should know what are all the mistakes we often do, and by demonstrating here we correct some few of our errors. And anatomically, this is anterior fontanelle. It's a diamond shaped, and it measures the few common things we know. This is 4 centimeter and 2.5 centimeter and AP and transverse diameter. And we should know this is basic anatomy, but how it plays a role in clinically we palpate the demonstration of anterior fontanelle.
Please come now. Now he's going to demonstrate first on this mannequin, and then we'll see how to demonstrate on baby. So when an examiner asks you, usually this question is asked by middle. Nobody asks directly to demonstrate. When you mention something, you give some hint or lead to the examiner, then he will ask you about these questions. In general, these questions are usually divided based on history, based on clinical examination, based on analysis. Last is diagnosis. So based on history, sometimes questions are asked. Then all these questions come under 3 headings. First heading is the student having sufficient knowledge? KAP. This is the usual format. K stands for knowledge. A stands for attitude of the person. And P stands for practical exposure or practice, or actually practical demonstration of all those things. So first of all, anterior fontanelle, what are the things will come? First is knowledge. So we'll ask few questions about knowledge to him, this one. Mike, you have mic? So anterior fontanelle. So usually questions asked on anterior fontanelle. What are the questions asked on anterior fontanelle? What are the causes of large anterior fontanelle? What are the causes of small anterior fontanelle? What are the causes of full anterior fontanelle, sunken anterior fontanelle? These are the answers you know already. For example, we'll ask him, what are the causes of large anterior fontanelle?
We see in Down syndrome.
They are your examiners.
We see large fontanelle in Down syndrome, hypothyroidism, and sunken anterior fontanelle in dehydration, and few fullness of anterior fontanelle we see in raised ICT, and sometimes we see in meningitis, which is a fullness of anterior fontanelle.
Here we get different types of students. Some students are having too much of knowledge, and they want to show the knowledge to examiner. How it starts? Under Russell-Silver syndrome, pycnodysostosis, osteosis imperfecta, and all those things. They have a big list they put. The examiners look at each other. Oh my God, he's a knowledgeable person. He looks like a grandiose. He just wants to know what he memorizes. What they want to know. Second extreme is this one. They keep on doing. Middle way is they want a sense of common sense. Means what are the commonly found a baby who is absolutely normal. He's not having disease at all, and he's having large anterior fontanelle. Commonly seen physiologically. Commonly, normal neonate, but he's having big anterior fontanelle. He's not having any abnormal brain or abnormal bones.
Sometimes crying makes.
Crying doesn't lead to large, it leads to full. Large anterior frontal commonly seen in IUGR babies. IUGR babies, we get large anterior frontal where baby is absolutely fine. So IUGR is another thing. Second thing, what examiner wants from this baby is large anterior frontal, this one, where we have to pick up a diagnosis, where we can help the baby. So what are the common causes of large anterior frontal? Common causes.
Sir, hypothyroidism.
Hypothyroidism, very good. Hypothyroidism, then malnutrition and hydrocephalus. So the examiner usually goes like this. There are different types of examiner, but they agree on one thing, that this particular student should not miss certain things. For example, malnutrition is there, hydrocephalus is there, hypothyroidism is there. In that case, anterior frontal will be large. So this is how it goes. Next thing comes up is his empathy. Whether that particular student is ready to harm the baby, just to demonstrate one sign, or this person is having empathy to the baby. For example, once you start palpating anterior frontal, your hand should be warm, dry and clean. Warm, dry and clean. These three are important. So many times what happens is that they keep on doing like this for a long time, this one, just to impress on this one. So it should be warm, dry, clean enough. Don't do too much of drama there. So suppose now we are palpating anterior frontal. How will you palpate anterior frontal? Usually what happens is, it's a good practice to talk and do simultaneously. Sometimes some people don't have that skill. Some people just stop talking when they are doing something, and the examiner is observed. So even if you don't demonstrate, if you know the system, they are happy. So talk, no, fine, it's okay, leave it. So talk and do simultaneously. So do palpate anterior frontal. Mike. Fine. So this palpating anterior frontal, what is required is you should not make the baby uncomfortable. Sometimes what happens is that the way in which they remove the cap itself makes the baby crying. Now once baby starts crying, anterior frontal will become full. So that particular thing we have to avoid. So without disturbing the baby, we have to palpate the anterior frontal. So just start. So as far as this anterior frontal is concerned, there are somewhat differences. Some people insist that this particular baby has to be somewhat elevated, 30 degrees or 45 degrees, so that false positively full anterior frontal will be missed. So in that case, show me different ways of palpating anterior frontal.
Sir, usually we do in two methods, in supine position normally in a newborn, and in an infant we see in an upright position. In supine position, make sure the baby, we do less harm by palpating anterior frontal.
Just started. they find out. Just because I have told don't do harm, you are studying. No, I won't harm the baby or something. No. But be natural, correct? No. Palpate anterior frontal. What is it?
Sir, by looking, we have to see are there any abnormality in the shape of the skull, and by using the soft surface, this flat surface of the finger, we just gently palpate the anterior fontanelle and anterior to posterior and to the transverse.
So here what they want is that you should not overdiagnose, you should not underdiagnose. So what are the things we are going to see in anterior fontanelle? One is size. This one, there is a method of actually calculating the size. So this particular size, common question asked in exam is this anterior fontanelle is there, diamond shape. How will you put the lines? From where you will measure anterior fontanelle?
Sir, from anterior to posterior,
So this is the commonest trap question. Usually what happens is that anterior fontanelle is diamond shape, but at anterior part and posterior part, this one, they are merging with the sutures. They're very difficult to know where the fontanelle stops and where the suture starts. So don't take that particular point as your point of interest. So already you described there in your slides how to palpate diagonally. Never measure anterior fontanelle like this. You do it diagonally. That important word is important. Diagonal measurement. So this is how they see whether the person knows about that particular method. Diagonal measurement, never transverse and AP. So now when you are palpating anterior fontanelle, we have to see to it baby is comfortable. Baby is not crying. That's enough. Comfortable baby, non-crying baby. Then you have to palpate with one or two fingers depending on size of the head. Palpate from lateral to medial and then again to lateral. Palpate from lateral to medial, again lateral. During palpation, what happens is that what you are feeling is bone. Then there is absence of bone, again presence of bone. Now, when you are going from transition from bone to skin, bone to lack of bone, in that case, what are the things you are palpating, looking for here? So when you are palpating from lateral to medial, again to lateral, this one. Now, this is important. Another thing is sweeping of fingers. You sweep the fingers from lateral to medial. Start sweeping the fingers.
Lateral to medial.
Medial. What are the things you are seeing?
Sir, from bone to, and it's bony surface, and we see the pulsation, any pulsation in the.
So this particular thing they want, whether pulsations are present or absent. One, good. Second, level. Whether the anterior frontal is at level, is it sunken, or is it full, is it tense? So pressure, and second thing is area, another thing is pulsations. So now you see from here to here, here to here. Now they will ask, some people ask more further, how to distinguish between your own finger pulsation and pulsation of the baby. If you are pressing too hard, you must have seen in pulse also, pulse. Even if the patient is dead, you feel pulses this one, because it's our own pulses actually, we are pressing too much. It happens. How to distinguish between your own pulse and pulsatile AF?
Sir,
so this question is not a common question, it's an uncommon question. Common question will be the diagonal thing and all those things. This is sometimes asked, those who answer well. So when you are palpating, you press it gently. Press it gently. On gentle pressure itself, you are getting pulsation, it is pulsatile AF. If you have to press deeply, and then you are feeling pulsations, that is usually, and which is very slower than baby. Your heart rate is slower than the baby's heart rate. So this is how we can distinguish between pulsatile AF and feeling your own pulsations. Then you will ask this one. Next, this comes under knowledge purpose. So two babies are having full AF. One baby is having pulsatile, one baby is having non-pulsatile. So which baby is worse? Non-pulsatile. Lack of pulsatility is sign of raised intracranial tension. So this is how the exam goes. Start. So basically I'm just giving one example that any clinical picture or demonstration or something, make a habit to have knowledge about it. Anterior fontanelle like this, never measure like this. Always measure diagonally. This comes in knowledge part. The aptitude part means don't make the baby cry unnecessarily. If the baby cries, rock the baby, console the baby, give the baby's own hand to suckle. In that case, baby will be calm and quiet. Second thing is knowledge is causes of large anterior fontanelle, small anterior fontanelle, premature fusion of anterior fontanelle, full anterior fontanelle. All those things come under knowledge part. And practical aspect is how to sweep your fingers across the fontanelle to see the level difference, to feel for pulsations, and to feel whether this particular fontanelle is unusually large or unusually small. So every sign you take during rounds or something, it's a habit. So that habit you ask yourself, what are the questions will be asked in exam? Fine, next one.
And next topic is the common things, very common reflexes we often do, and we make some mistakes. In that, we start with Moro's reflex. Moro.
How to demonstrate Moro?
Sir, usually we divide this thing. Basically, the stimulus and what you get the response. After that, what are all the significance? Whether it
please come. Demonstrate the Moro. Demonstrate Moro reflex. So when you this question is come actually. These are actually common questions. Every examiner they ask these questions. Demonstrate Moro reflex. Now in Moro reflex, what happens is that this one you should have knowledge, you should have aptitude not to harm the baby, and you should be able to do it very smoothly. Yeah. So how to demonstrate Moro reflex?
Sir, before doing Moros, we should all the reflexes basically it looks somewhat awkward to the mother. We should give confidence by handling the baby. Few things is keep the things, the surface of the please do the Moros should be smooth and soft, and gently handling the baby and positioning the positioning of the baby. There are two things in positioning. There are two ways we can do the moros. One in supine one. One more thing is we can keep the baby at 45-degree angle. We can suddenly drop. This is a stimulus. When you suddenly drops the baby, the extension of neck gives the response. So we see the how we keep the baby's position. We should gently hold the baby, and it should be like this. And you're not supposed to hold in a very awkward manner because it's a crude procedure. So you should keep the we should keep the things proper, and gently we have to the things before doing that. What are the things we should know? Holding the baby first, we are going to give the stimulus.
One second. What is happening here is, other than answer, he is telling all those things. Correct? This time is not there in exam. They are moving on.
Yes.
This particular thing, don't wait too much of time in that building up the things and all those things. So this is a question answer going on. This exam, many people do that. There's so much of time in that. Come to the procedure, demonstrate, and move to the next question.
Stimulus. Here comes the stimulus. Sudden dropping of the neck. Means give the response, which is abduction at the shoulder, extension of the shoulder, and the extension at the elbow joint, and opening of the hand. And with main thing is the following things. Tensing of the neck, changing the posture, and it comes back to the flexion. This is a complete starts and ends with the Moro's reflex, and few other things. It starts how other common things.
Another common mistake. If question is asked, you answer the question and stop, because question is not about interpretation of Moro. Question is demonstrate Moro. So I will tell you, what happens is that you do it, practice at your home or a hospital or something, to talk and do simultaneously. As far as demonstration of Moro is concerned, baby should be in comfortable position. Second thing is, if the baby is sleeping or something, gently awaken the baby. Suddenly taking Moro reflex, the baby who is sleeping is very torture. So awaken the baby. Let the baby go into some different state of awake and quiet or awake and active. Then the whole idea is to cause suddenly the extension of neck. Your hand should be covering upper part of back, neck, and lower part of head. Your hand should be covering upper part of back, neck, and lower part of head. Majority people don't do that. They hold the baby like this and drop the baby like this. Now see, it is very actually painful. So you hold it, then you adjust the angle. Now what has happened with this angle between the chin and sternum? I have made it like this, gently. And then when you do that, you should do like this. But at the end, you should be there to support the baby. At the end of fall, if the student does not have the hand here, it is considered to be bad class. Don't worry about the response. Many people, they want to elicit the neuro fully and all those things. Till they don't get, they keep on doing it. So avoid that, this one. So I'll repeat, this particular hand, your hand should be at upper part of back, neck, and lower part of occiput. Cause some gentle flexion. Keep the baby slightly upright. And then leave your support to cause sudden change in neck position, that is extension. And at the end, you should be able to hold that. Now you can describe the response. Describe the response of Moro. What happens in Moro once you do that?
After the extension of neck, it gives a response in abduction in shoulder joint and extension of the shoulder joint.
Abduction of shoulder.
Shoulder.
Extension of shoulder means what?
Sir, extension.
This is another common problem, because this is abduction adduction. What is flexion and extension of shoulder? No. Flexion and extension. So abduction, extension at elbow. Then
opening of
hands, and followed by
flexion.
Cry, change of position.
Cry
and change of position. And then the things come back. So this is how the exam goes. This one. So they know what is the common mistake of the student. Many students don't know what is extension of shoulder. So extension of shoulder is different, and extension of elbow is different. Then opening of hands, and then adduction and embracing positions. Then some people can ask you, what are the causes of asymmetric Moro? What are the causes of asymmetric Moro?
Birth injuries.
Tell them.
Asymmetric Moro is seen most commonly in the birth injuries and fracture clavicle.
When there is pain, baby is unable to move that. What are the causes of pain? Fracture clavicle, humerus, this all the birth injury. Second common cause is paralysis. What are paralysis? Cause of paralysis?
Hemiplegia.
Brachial plexus injury. Brachial plexus injury and pain. So paralysis, one group, pain, one group. This one. So these are the two common. How do you differentiate between paralysis and pain in a baby? Suppose a baby is not moving one limb adequately. The pain can be there, paralysis can be there. How to differentiate between pain and paralysis in a baby?
By consoling it, will.
Because this particular question looks like people think it is unexpected question. Correct. I told asymmetric Mero, everything, this one. So this pain and paralysis distinction requires immediate application of common sense. Now, this baby, the mother brings you saying that this particular baby is not moving left upper limb. Whether it is because of pain or because of paralysis, how do you distinguish?
Sir, other grips and
grip.
Able to
baby is not able to move left upper limb. Mother has brought this baby saying that my baby is not moving left upper limb. Whether it's because of pain or paralysis. Because of depending on that, your referral starts. Whether to ship the baby to orthopedician or whether to refer the baby to neurologist. That decision depends on this. So they ask this question: how do you differentiate between pain and paralysis? Left upper limb is not moving. Presence of tenderness, swelling, and history. So how will you elicit tenderness in left upper limb?
Sir, gentle pressure over the anterior part.
This is the difference between orthopedician and pediatrician. Orthopedician, what will you go? No, you show this is pain. No, he will see to it that you get more pain. And pediatrician doesn't want to elicit pain actually. This is called aptitude. So suppose just ask the mother whether baby is having any pain, and she will tell you yes, because mother has already palpated the hand. So ask the mother, is there any area of left upper limb where baby is having pain? Avoid that area. That area you come last. Orthopedicians come to that area first. So this one, suppose she is not able to tell that there is some area is pain or something, then there is a system of palpation. For example, common causes: fracture of clavicle, fracture of humerus. So how would you palpate the clavicle?
Sir, we can go medial to lateral or lateral to medial.
What an answer! Good. I can go from Bombay to Pune or Pune to Bombay. This one. So this one, how is the method?
Sir,
because that depends on what are the commonest sites of. Because by this answer, you are judging what is the commonest site of fracture. It is near the midline or away from the midline.
Near the midline. Away.
Understood. No, this is how the exam goes. This is examiner wants to go deep into that, how much he knows, how much he doesn't know. So this particular thing is, this particular palpation should be always from lateral to medial. Lateral to medial. Usually what happens is that between that 1/3, 2/3 junction, then you get crepitus, then you get tenderness, then you get swelling. Crepitus and tenderness, you get here, this one. So method is start from shoulder, acromion process, slowly palpate
lateral to medial,
and don't use very little force, because some people use so much force that even normal baby also will cry. So this one, use a slow little force so that you will be able to diagnose fracture clavicle. Now fracture humerus.
Sir,
whether to go from below up or up about onwards.
Sir, from above to down.
Very good. So this one, you palpate from shoulder. This is a firm pressure. This is a firm pressure up to the elbow, and you find any step, any gap, any swelling, any tenderness. So if that is found, then refer the baby to orthopedician. If it is not found, then you refer the baby to neurologist. Now some people, they will go somewhat more in deep. Suppose baby is not moving one upper limb. Baby is not moving upper limb. When to admit the baby in ICU? Whether the baby can be managed on OPD basis or whether the baby should be managed in ICU.
Sir, few common things. Sir, whether able to flex and having the movements of the fingers and
Baby is not moving upper limb. Mother has told, baby is not moving upper limb at all. And there is no pain. This is paralysis. Vitals. What vitals do you see here? Because these are the questions, no, these are questions are not told. Because assume that examiner want to know whether this particular person can actually take quick decisions based on that so that baby will be safe. So baby is not moving upper limb. What are the ways in which baby can have life-threatening problem? Is diaphragmatic paralysis. Diaphragmatic paralysis, because these segments which are going to upper limb, they are the same segments which go to diaphragm. So how will you diagnose diaphragmatic palsy in a baby with upper limb paralysis? Diaphragmatic paralysis. What will happen? This particular the diaphragm contracts. Once diaphragm contracts, chest becomes big and abdomen becomes full. Correct, no?
Yes, sir.
In diaphragm is paralyzed. What will happen there? What are the signs you will get? We'll get one is paradoxical breathing. Second, we get deep subcostal indrawings and preference of the baby to lie on one side. Mother will tell that if you keep the baby laterally, he's fine. If you keep the baby supine, he's breathless. He is unable to feed in supine position, but he is very well able to feed in lateral, one lateral position. Opposite lateral position, he is not feeding. He is feeding only on one breast. He is not feeding on other breast. So this particular preferential lateral position, respiratory difficulty, subcostal indrawing, paradoxical breathing, that will tell about diaphragmatic pulse. In that case, that baby should go to ICU or saturation monitoring, and if required, any respiratory support or something. Baby should not go to orthopedician, baby should not go to neurologist, baby should go to ICU. This is the way in which exam goes. So-called unexpected questions are actually related to practical implications. So this is how we started. We started with anterior fontanelle. Second, we started about Moro, asymmetric Moro. So every demonstration, then knowledge about it, aptitude about it, all these things are tested. Fine. Next one. Next one.
Sir, next one is a palmar grasp reflex, palmar grasp. Sir, demonstration part.
Demonstrate, palmar grasp. Here you can demonstrate.
Sir, usually baby closes, with the closed hands it will be there. Gently we have to touch the dorsum of the hand to open and introduce your finger from the ulnar side of the baby hand. So it will catch the hand. If you try to remove it, it will again give the grip. This is a palmar grasp reflex.
Very good. First time he has answered very nicely. Correct, no? Understood. He didn't go for any. I'm very happy. This is how answer should be good. No any drama, no any too many things. He directly went to the point. First, what he said, stroke the dorsum of hand so that baby will open hand. Don't try to force it open. Some students do that. They are fighting with the baby. They are forcing open, baby is clinching this one. So gently stroke the dorsum. Let the baby open hand. Then he told, very importantly, approach from ulnar border. Yes, ulnar border with little finger. Then what will happen, once you stroke this surface, baby will grasp the finger. More you try to remove, more firm will be the grip. This is palmar grasp. Fantastic. Good. Next one.
Sir, next one is plantar grasp.
Yeah, definitely will pass.
Sir,
Demonstrate to them.
plantar grafts, basically the stimulus should be given and the anterior part of the sole. Gently, somewhat deep press, the baby's toes and fingers crawls your finger. That's the reflex of the plantar grasp.
Good. So now what he has said, most important part here is anterior part. Suppose if you stimulate instead of anterior, posterior part, heel. What reflex you are demonstrating?
Sir, posterior gives you Babinski.
No. Posterior. I am not saying lateral. So there are three things. One is anterior part, one is painful stimulus here, and second is lateral. Lateral is for Babinski, here is for withdrawal, and here is for plantar. So these are the three things we can do from foot. That is plantar grasp, withdrawal, and Babinski. Good. Next one.
Next one is atonic neck reflex, asymmetric tonic neck reflex. The demonstration part.
Now we can see with baby now. Can we go down or shall we take the baby up? We'll go down there. So now he is going to demonstrate on real baby, because in the exam they're going to be a real patient. This is ATNR. Carry on. So talk and demonstrate.
ATNR. ATNR, the stimulus is when you passively or actively rotate the basic thing. The common mistake, don't use your dominant hand.
Common mistake he is telling in the exam, this one. No, it's an exam question, you demonstrate, no. Again, don't go back to the original thing.
Okay. We are not,
Demonstrate ATNR.
sir, slow and gentle turning of the neck of the baby
Fine.
gives the extension of the same side and a flexion of the opposite side.
Fine. Leave it. What happens is that, first of all, we have to undress the baby completely. Because this particular baby is so much covered that very difficult to know what is flexion and extension and all those things. So first step is undressing the baby. Second thing is turning the head to one side. When we turning the head to one side should be smooth. And then you observe the position of the limbs. This one. Remove this one. And we'll demonstrate ATNR. Good. Enough, this one. This is enough. So now you turn the head. One second. Leave it. So this turning of head, this one, should be actually done in a gentle manner, so that whole idea is to touch the chin to the shoulder. Ultimately, you should be in one line. So that particular turning, when you are doing this particular baby should be actually calm and quiet ideally. The baby is not calm and quiet, is crying and all those things, we can't demonstrate. So we can tell the examiner that this baby is quite active, this one crying and all those things. I would like to pacify the baby, and then we can examine. They forgive you. So you should not try to make. Second thing is, what mistake you did is that with this particular baby, you handle the limbs. So don't touch the limbs. Ultimately, we are going to see the baby's movement of limbs. So we have to console the baby. So sometimes we feed the baby also. And then we can try to turn this one to one side. Once you turn to one side, then you observe, keep it for some time, and we can see the response. This one. So now the baby is crying, so we not possible to elicit completely. So we should we again force it again. You to mother. Mother is there? Mother. Please come. Take the baby. Put your hand here, like this. Take the baby. Fine. So this ATNR thing, this one is the, what is the significance of ATNR in babies? Please come. Then suppose there is no demonstration possible, then they ask for some theoretical questions. What is the significance of ATNR in these babies?
Sir, if ATNR persists more than 6 months.
Abnormal prolonged persistence of ATNR beyond half year of age indicates
there is no other crawling or rollover. The other developments delay will be attained.
It indicates persistence of any primitive reflex beyond certain period of time indicates neurological dysfunction. Simple. So try to make the answer very simple. Don't make it complicated. So persistence of all the reflex, it's given in books. Beyond certain period of time, if it persists, then it tells about some amount of neurological dysfunction. Okay.
Next come the rooting reflex. Demonstration part. Rooting reflex, the thing is, we have to gently touch the baby's corner of the mouth, and we have to slide it away from the corner of the mouth.
Corner of mouth, go from angle of mouth to away.
Away.
We can feed the baby. We can ask the mother to go and feed the baby. So touch the corner of mouth and go away. What state of away wakefulness baby should be there? Or eliciting rooting reflex?
Sir, away. You should demonstrate the rooting reflex in awake state.
Awake
And
state.
Awake and quiet.
Awake and quiet state.
It should not be crying, sir.
Should not be crying. Sometimes this is called echolalia. Sometimes examiner says, student also says the same thing. Sometimes student says, examiner also says the same thing, just to demoralize him. This is a common tactic. We should not worry about, get the hint of it. What examiner wants to know? Sometimes they say examiner is irritating this one. He's not irritating. He was telling you. They want to test your knowledge about the states. What are the states you know of the baby's sensorium?
Sir, deep sleep, quiet sleep,
Deep sleep, light sleep, drowsiness, awake and quiet, awake and active and crying.
cry.
Correct. Now, in which out of these 5-6 states, which state this rooting reflex is best elicited?
Sir, awake and quiet.
Awake and
Quiet.
active. Awake and active. Because awake, he's moving. He did not elicited quite well in drowsy state. Second problem comes up is just like what happened to this baby. He was too active to elicit anything. Correct? No? Active and crying very difficult. Awake and active is the best place when we can actually elicit this one. So you tell me, suppose baby is sleeping, an examiner asks you to elicit reflexes, rooting reflex. How do you wake up the baby?
Sir, gently touching the baby and we have to gently rock the baby to get the arousal.
So this one, seeing the baby's eyes is different. What you're telling is how to make the baby open eyes. This deep sleep, light sleep, drowsiness, awake and quiet, awake and active and crying. So these things, there are two ways in which either how to make the baby from here to here or here to here. How to make the baby from here to here is by stimulating the baby. Stimulating the baby means stroking the feet, deep pressure. Second is gentle pricking the soles. And then, if required,
Gentle rocking.
rocking the baby. So by doing these three things, baby can be brought to desired state. The baby cries too much, for example, this baby. What is the cause of this cry? Maybe cold, hypothermia, or hunger. Hypothermia or hunger. So maintain temperature and give feeding. Maintain temperature, give feeding, baby will automatically go to the desired state. Now suppose baby is in awake and active state. How do you elicit? Rooting reflex. Hands should be dry, clean and warm.
Sir, by gently touching the corner of the mouth, angle of the mouth, and slide it away from the
Other common mistake is people touch direct too much near the mouth. Don't go too much near the mouth. Slightly away from the corner of mouth, stroke outwards. What response you get usually?
Sir, opening of the lower lip to the same side
Opening up mouth, then
lower lip,
then
and tongue moves towards the stimulus.
And baby turns towards
to the
stimulus. Baby turns towards stimulus as if baby is going for nipple. This is rooting reflex. Fine.
Sir, next one is sucking reflex. And sucking reflex, gently we have to, in a clean, warm and dry finger, we have to, on the soft surface of the finger, soft.
Will you put finger like this or like this?
Sir, like this.
This is another problem. Usually nowadays in exam, nobody is asking for sucking reflex. But they want to know, when you are putting finger inside, your nail should be cut short. And nail should not hit the palate. It will lead to palate injury. So your nail should be abutting on the tongue, not on palate, this one. The second thing is your finger should not be too deep inside. Maybe you'll have gagging and retching, vomiting, aspiration. So this particular thing, once you put your finger inside, what are the things you'll see?
Sir, vigorous sucking of the finger.
Frequency of sucking, strength of sucking. Frequency of sucking and strength of sucking. These two things commonly we see in sucking reflex. Nowadays, nobody is asking sucking reflex to demonstrate. But rooting can be asked, ATR can be asked, and monoreflex can be asked. Fine. Then they want to know about certain practical aspects when they ask for something. What is difference between sucking process in a breastfeeding and what is different sucking process in bottle feeding? They call it nipple confusion. If you give bottle feeding early, sometimes babies find very difficult to latch on breast. Why?
Sir, hind milk.
So this one, when you go for breastfeeding, what is the process? This is the hard palate. Here is the tongue. Now your nipple is in between. And tongue, what happens is that tongue presses the nipple and areola against the palate. So it is like this. This movement is like this. But in bottle, what happens? There is biting. There is biting. The baby exerts the pressure of these alveolar ridges on the nipple. So this is like this, and breastfeeding is like this. So that particular thing you should know. Why it is important is, if you give baby bottle feeding, baby learns to bite, and this biting actually can cause pain in baby. So baby, we should not use bottle in early few days of life. So this is practical points they ask. They ask for something attitude, they want knowledge of sucking, they want what is the practical aspects of this, KAP. So these are the 3 types of questions asked for every topic. Next. This is another common question asked is, how to differentiate between convergence and jitteriness? Tell them.
Sir, jitteriness, we often confuse with jitteriness and convulsion.
Don't use this word. We often confuse this one. The whole idea is, what is difference means what is difference. You tell them.
Sir,
Doesn't require. Correct.
Sir, jitteriness basically a fine tremors. When we give a passive flexion, the jitteriness can be stopped. Convulsions will be irregular and jerky, sir. It won't stop. And
just read, no, read. No
sir,
problem.
eye signs are basically associated with convulsions, not with the jitteriness. And autonomic signs like tachycardia.
Jitteriness happens only when baby is awake. Conversion can happen in all states. This is one thing. Second thing, jitteriness is symmetrical. The movement what is getting jitteriness is symmetrical. In convergence, it is asymmetrical. Fast component, slow component. Fast component, slow component. Myoclonus also, it is asymmetrical. So this is asymmetrical nature goes more in favor of convergence. Symmetrical nature goes more in favor of jitteriness. Jitteriness stops when you hold the baby. Jitteriness happens when baby is awake and active. So second thing is that associated vital signs, eye signs are present in convulsions. This is very important. This particular thing is not an exam question, because maybe we go for LSCS calls, baby is asphyxiated, we restate successfully, and then we have to demonstrate it to a grandmother. Grandmother, we have to tell that when this thing happens, immediately inform doctor or sister so that baby can be shifted to ICU. Because this is not told, many babies actually develop cord deaths. They are found dead because they convulse silently, and convulsion is actually mistaken for jitteriness. So jitteriness and convulsion, it is how to differentiate, how to stop, what is pathological, what is physiological, what is practical implication they want to know. Fine.
Next one is how you palpate the cephalometoma.
How do you palpate for cephalometoma?
So the cephalometoma basically it's anatomy, and it is an subperiosteal collection of blood.
That is not the question. What is the question? How do
Sir,
you palpate cephalometoma?
If I see the swelling in the left side, I will gently touch the cephalometoma and moves from front anterior to posterior. How the nature, bogginess or any ridges we have seen.
There is a difference between palpation of AF and palpation of cephalometoma. What is palpation of AF? We know this particular AF is a diamond shape. So we are sweeping our fingers from right to left or left to right. This is anterior fontanelle. Cephalometoma is not like that. Cephalometoma is sometimes visible, not visible. Cephalometoma happens usually at parietal regions. So here the idea is actually cupping round. Here it is straight. Anterior fontanelle, your fingers are straight. And in cephalometoma they are round. And you try to approximate it and sweep your fingers. You don't palpate with one finger, 2 fingers, all 4 fingers. All 4 fingers you are palpating according to the contour of chest, contour of skull, not like this. According to contour you palpate. Once you palpate that, then you start from first of all skin. Then you get ridge. And once you get the ridge, then you have to palpate whether it's having underlying fracture or something, all those things. So there is a difference in palpation of anterior fontanelle to palpation of cephalometry. Fine. This is over. No, time is over. So we will go for last summary and we'll stop this.
Sir, next one is how do you examine the jaundice baby? How do you look for the jaundice baby? And few basic things to be done, and on a good light and for unbutton of the dress of the baby on a bright daylight, we have to see from head to toe.
Please show me how to see jaundice in a baby. This exam, this 100% this question is going to come in exam. How will you look for jaundice in a neonate?
Sir, first of all, uncover the dress or unbutton the dress, and gently starts from on a day bright light. We have to see from the head to toe. Just gently press and feel for the see the blanching of.
This is the keyword, blanching of skin. Till that time, examiner won't be happy. You use the word blanching of skin by applying pressure. Blanching of skin by applying pressure. Avoiding soft tissues. Blanch usually against the bone, either forehead or sternum or thighs or legs or feet. The blanching of skin. Blanch the overlying skin and then see the underlying color. This one. This is how they expect. Unless until the blanching is not used, this one they won't be happy. So my carry-on message is every demonstration has got some keyword. So that keyword must be followed, associated practical implications, and don't harm the baby about that. Then everything is easy. Thanks a lot. Thank you.
Thanks.
Thanks.